Thank you, and thanks for all attending. I think it's the third in our series of summer half-hour lunchtime sessions where we speak to important, influential people in the kind of sphere of practice management and organisations that support us, assist us, and that we are going to work with moving forward. And today our session is with Vicki, who is the Deputy Director of Inspections, is that right, Vicki? And of CQC. So we've just got a couple of little updates to do first. And as normal, we're going to use Menti. So just to get you warmed up, we wanted to take a snapshot of where you are. So if you can go on to Menti and just tell us where you are today. I'm guessing that first one on the map is Robin in Bristol. Yeah, big grin, Robin.
Always.
Yeah. So it looks like we've got someone in London. So the Menti code is 58516799. You'll have to imagine a little one in Mancunia for me, because I cannot multitask. Oh, great! Lots of dots. And we recognise that we might be very England specific today, because CQC, of course, is an English organisation. Great, good spread. Thanks, everyone. So I won't go through who we all are because I think you know us by now. I'm hoping Nicola has joined us. If so, you've got all four directors with you today. First bit of update, Robin, we'll hand over to you for the New to Partnership scheme.
Yes, thanks, Kay. So hopefully you will have all seen that last week on Friday, we released this statement expressing our displeasure and disappointment, essentially, at no progress being made with the New to Partnership scheme. And we were hearing from a lot of our members that while they were submitting applications for clinical applicants, they were being told that the deadline is March 2022. So we were even more concerned then that the scheme was essentially going to run out on us. So we released this on Friday. To date, we haven't heard back from NHS England, unfortunately, but they are still in a bit of a standoff with the BMA and GPC from what we hear. We did, however, manage to speak to Krishna from GPC yesterday, who wants to reassure our members that the scheme is not ending in March 22, that there may be some confusion around how this has been communicated, but his expectation is that it's going to continue. And that essentially practice managers' inclusion is still very high on the BMA and the GPC agenda, and they will continue to fight for this in their conversations with NHS England. So as soon as we hear any more, we will pass it on to you guys, but we want you to just know that we're still championing this cause and we're still bringing it up at every possible opportunity.
Thank you. And we didn't get a reply back from Nikki, maybe because she was on leave last week. So we're still hopeful to get something from her once she's caught up. Okay, so just a kind of test the water with you all, really. If you were offered partnership at your current practice, would you accept it? And I suppose this is separate from that that sort of scheme, really. Okay, so we've got lots of practice managers interested in that partnership option. Fabulous. That's great, you brave people. And I guess some of you are already partners anyway, so may not be answering that question. Okay, so if Nicola's here, I think we were going to go over to her with the Support Your Surgery campaign. Anyone seen Nicola come in? No? This might be down to Robin or Joe then, if one of you could pick this up.
Yeah, I'm happy. So you might have seen from the BMA social media this morning that they have launched a new campaign, #SupportYourSurgery. It's basically calling on the government to properly fund general practice, to make sure that we have enough funding for management costs to be able to get staff in and to be able to house staff. So it also highlights how premises need improving and funding as well. So we have put it out on our social media. What they are doing is sending a pack of resources to each practice addressed straight to you as the practice manager. It's really nice to talk to Krishna yesterday, who explained the reason they've done that is because they value what we have to say and appreciate that we are probably the ones who are going to manage all of the comms that come out of our practices as well. So look out for that in the post. We're basically wanting us to encourage patients to sign this petition and support their surgery to the government and just get overwhelming, patient support to improve access to general practice funding and all the things that come with it. So if you do see it online, please do promote it. Please sign the petition yourselves and get your staff to do it. You can put it on your practice social media, and you can send it out in patient newsletters, etc. I've already put it on my practice's website today. So keep an eye out for that and please do spread the word.
Thank you. Okay. So, Vicki, I've given you a completely wrong job title, Deputy Chief Inspector of CQC. Vicki, I stole all of this off your LinkedIn profile. Anything you want to add about your background before we get going with the questions?
Yeah, so hi everyone, really delighted to be able to join you all today, and fantastic to have the opportunity to speak to, I think there's over 150 on this call, practice managers. So Kay and colleagues, big thanks for inviting me. Yeah, so I'm Deputy Chief Inspector. I won't spend a lot of time talking about my background, but I've got a sort of vast regulatory background, as well as being a registered nurse, so worked clinically in the NHS and the independent sector before moving into regulation.
Fabulous.
I'm the national lead for the regulation of GPs, and I have a portfolio across London of the regulation across health and social care. So my sort of operational day job is London, but my sort of national lead is the regulation of GPs, and that's around day-to-day regulation of GPs, but also the development of our approach to regulation overall, which I know I've seen some of the questions, Kay, and hopefully I'll be able to talk a bit more about our transformation, and it connects really well with the questions that you want to talk to.
Fabulous, thanks Vicki. So as normal, we go out to our community, so our members of IGPM, and ask them what questions they want to ask you, just so that we get it bang on and absolutely right. Just a note, somebody's got their pen working on the screen, so the red lines are the pens of somebody. I can't tell who it is from here. But that's not me crossing through a question. So we've done 5 topics. So the first topic is really about that review system of inspection. So can you explain it? Is it a more supportive approach? And are there any top tips that you could share with us, Vicki?
Okay, so what I think would be great, Kay, is if I can talk today about what our approach to regulation is at the moment. So for the remainder of this year, it'd be fantastic to come back to talk to you a little bit more about how we're sort of shaping the future, and how we'd like to connect with you about sort of influencing how we regulate in the future. So I'm going to focus on today and this year, so to the end of March, what regulation will look like and feel like. So for the remainder of this year, as we have been doing during the pandemic, our scheduled inspection activity will be based on risk. So that's known risk and potential risk. So we will not be inspecting in accordance to our previous inspection frequency. So 3 to 5 years for good and outstanding practices, 6 months special measures, a year requires improvement. So we will be inspecting in response to risk, and within the that risk portfolio is also our follow-up inspections when we need to. So at the moment we will be doing some inspections of practices that are triggered through risk, and also following up for practices that are rated requires improvement or inadequate. We have developed and continuing to iterate the way we monitor general practice So we, during the pandemic, we've had the opportunity, and it has been fantastic, and we've made great strides in being able to understand a lot more about how practices are running and outcomes for people without actually stepping over the threshold into an inspection. We've got a long way to go with this, but we've really made great strides. So around 70, I think it's around, and it changes slightly and will change slightly each month. But this month, 76% of GP practices will have what you might refer to a banner or a statement that is refreshed on a regular basis. And basically, that statement is saying that with all of the information that we know about you as a practice, we're not planning any inspection activity. It's not saying there is no risk, and it's not saying that we it's not an accreditation of a previous rating. It's saying at the moment we're confident that we can continue with a monitor approach. So that's 76% of practices. And then the remaining practices, a small percentage of those will definitely get inspections. They're the ones that I've talked about. And then there are sort of, I think, around 18% this month of practices. I'm going to refer to those practices as on our sort of closely watching practices in terms of monitor. And they are the practices that will be making contact with you in a similar way to the way we did around the emergency support framework at the beginning of the pandemic. So there will be some information that we hold that is triggering the need for the inspector to have a conversation with practices, really to gain assurance and to assure us that actually there is no risk to people using services, and we can continue in that monitor space. And what may then happen is that those practices may then move into the group of practices that don't require an inspection and will get the statement or the banner on the website. So that's kind of, I can send you some slides with a bit more detail, but that's going to be our approach for this year.
And we've got another question around that information as well, Vicky. So that'd be really useful if we could think about what that information is as we move forward, that kind of triggers your phone call to us or your visit. Fabulous, thank you.
So the questions here, Kay, it's not necessarily an annual phone call. It will be a phone call as and when we think that we need to make the phone call. So for 76% of practices, that annual phone call isn't going to naturally happen.
Okay, and the system is changing in April of next year, and we'll set something up maybe February time, shall we? And you can tell us a bit more about.
Yeah, absolutely, and we'll be updating Kay through the GP reference group.
Okay, fabulous, thank you. So, if we've got a new practice manager on the call today, can they get support from you specifically, and can we make a relationship with our inspector outside of the program?
Okay, so the answer is yes, please. So at the moment, in the future, I don't know how this is going to work. I'm being totally honest with you. We're talking about the best way to have relationships with providers with our new regulatory approach. But as it stands this year, we absolutely want to have that engagement relationship. It's really important for our inspectors to have a relationship with practice managers. We welcome it. We would far rather have the relationship and for practice managers to share information with us. And when I mean share information, I don't mean produce a lot of information, but if you're aware of a risk associated to your practice and that you're addressing the risk, it's far better for you to let us know about that. This isn't about required notifications. This is, if there's something that you think may come to our attention, if you've got a particularly challenging complaint or something that's really generating concerns for you as a practice and may come our way through another route, please do make contact with us. Make contact with us, let the inspector know that there's a particularly challenging time for you as a practice, what you're actually doing about it. And it really helps us to be able to develop that assurance. So yes,
great.
Welcome it.
And we're doing some work in the background, aren't we, Vicky, where we're going to try and map our regional reps for the IGPM to your regional inspectors, so that practice managers perhaps just have one route in and they'll get to speak to the right person at your organisation straight away. So if in doubt, speak to your regional rep and we'll be able to kind of through. Yeah. Okay, great. So a question that we've had lots and lots of comment and questions around information. So what do you get?
I think she was trying to say, what information do you get, Vicky? What are you monitoring us on?
What do we use?
Yeah.
So what I can do, I can send you a slide or two with a bit more around the data that we use.
Yeah.
So there is the data that won't be of surprise to you. We're having conversations about QOF data. We have relied on QOF data previous years. We know that is going to be less reliable for us to be able to use to understand more about risk. We use patient survey information, appointments data, etc., etc. So I'm calling it a data set that feed into our system. But the other things that we use are general inquiries, so any safeguarding concerns, any whistleblowers, any complaints, any MP correspondence, any information that the public share with us about their experiences, both positive and negative. You'll probably all know about the Share Your Experience link on our website, which is where the public can go and share their experiences. Please promote that within your practices. We tend to receive more negative feedback through the Share Your Experience. It's understandable, because if people are getting a really positive service, they don't tend to look for ways to feedback. Some practices encourage feedback through Share Your Experience, and we would welcome that to get the balanced experiences from people.
That's a really good tip. Thank you.
Yeah, so we're not, there isn't really anything secret that we're monitoring. It's data that is known. The only things that you probably wouldn't be aware of, if there are any whistleblowers or safeguarding information that's coming to us, we tend to find that, and it is no surprise, but people that tend to whistleblow in primary care tend to whistleblow because they don't feel safe to speak up in their own organisations. So organisations that have got a really good process around whistleblowing and speak up, that we tend to get far less information of concern coming. So there's definitely a correlation there. So the more practices can do to make their own teams aware of who and how to speak up, I would suggest the less chance there is of us whistleblowers coming to CQC.
Fabulous, thank you. And I'm sorry if my screen, my connection isn't very good. We're just back from holiday last night, so we've got a house full of people on the internet. Okay, so topic 4 was around workload. So I don't need to tell you about the demands.
Yeah.
I guess we've probably covered this, because you're saying you're not going to do routine reviews, and if you're going to come out, it's because of an issue and one that's kind of serious enough for you to come out. Is there any leeway around dates and times that?
Okay. So if I can just touch on the workload at the moment across general practice, and as a regulator, what we're hearing and what actions we're taking, if that's all right, Kay. So we have general practice has always been challenged. I've regulated general practice right from the days we started registering general practice. So I'm kind of well sighted on the challenges over the years with general practice, but certainly now, within the last, I would say, 2 or 3 months, we are, well, it would be remiss to say that we weren't fully aware of the pressures across the sector. We have been holding some listening events with provider representative groups as part of our GP reference group, and specifically doing a piece of work about experiences of people working in general practice. And I feel really strongly that, of course, I am sensitive and mindful of the pressure that GPs as clinicians are under, but it's really important for me that we recognise that the pressures are across everybody working in general practice, and this isn't around pressures for clinicians, it's about pressures for everybody, not least practice managers. So I just wanted to share that with you, and it's really important for me that the regulation of GPs isn't about GPs, it's about the whole practice team. So we are, as a regulator, we've got a responsibility not only to regulate individual services, but also to understand what experience the sector are experiencing, and also to use our independent voice to speak up around that. So we are doing a specific piece of work around the sort of sustainability and resilience of general practice. And as a regulator, we've got a responsibility, we know, to make sure that we do everything that we can as a regulator to make sure that the way we regulate is as least, I don't like using the word burdensome as a regulator, but actually as least invasive and resource intensive for practices. So there's a number of things that we're actions that we're taking around that, not least the work around building our monitor and assess methodology and inspecting focused on risk this year. And we're also in close contact with NHS England around this, sharing with external stakeholders what we're hearing from people working in general practice. So I just wanted to share that, and you know, that we're absolutely on this. Rosie, our chief inspector, has spoken out about this. I'm not sure whether you've seen it. She's spoken out about it at our board meeting that was quite widely publicised. I was meeting every week. I now meet every month with the RCGP and the BMA, and as you know, we hold a reference group with wider representatives, so we're very close to that. Demands and inspection, again, this is about speaking to your inspectors. This is about you and your inspector understanding you, and you understanding if the inspector needs to inspect, what is it that they need to look at. We're not doing comprehensive inspections at the moment, so our inspections are all targeted. Okay. So a full comprehensive inspection of 5, looking at 5 key questions won't and shouldn't be taking place unless there is a potential risk across all of those questions, which is usually that's pretty unlikely, to be quite honest. So our inspections are much more targeted.
So they'll be in touch with you and say, we need to look at this area. Can you provide X, Y, and Z evidence for us? That could be provided over a telephone call rather than a visit. Yeah.
Yes, we will do whatever activity, and that includes, some of you will have been part of clinical search activity that our GP specialist advisors do, and that methodology has been built during the pandemic, really effective. We get some very positive feedback about it. At the moment, it has to be it has to be carried out with the consent of the provider. But actually what our inspectors should be asking is, what is it that we actually need to step over the threshold for, and what evidence can we gather through other means?
Okay, and that's all between now and the end of March, and then this new process will start in April, and we'll all be well prepared for that. Just to say, the reference group, the IGPM, are now members of that reference group. So again, speak to your reps if there is anything you want us to take to that meeting, and we'll feed back to all of our members of any issues or any questions or anything we think that is important to share back. Okay, really conscious of time. So is there any correlation between highly performing practices and non-clinical leadership, and how are you ensuring you're linking with the profession?
So linking with the practice management profession, clearly, I mean, this is just a very welcomed opportunity, and I think sort of keeping in close contact with you, and more than happy, Kay, for you or colleagues to come directly if any queries come in. More than happy, you know, to be a key contact for you. I would really like to get the regional links established. Yep. So that we can get a little bit closer to what's happening, because I think it's important to understand the challenges in particular geographies. Yes. So it's not the same, you know, from one to another. The question around correlation between highly performing practices and good non-clinical leadership, it's a really interesting one, and I think it does connect to the way we are developing our regulatory model for the future, because often in general practice, which is unlike possibly adult social care, registered managers in general practice aren't always the providers, the registered provider. So it's quite difficult for us to understand when you talk about good non-clinical leadership. There isn't really a way of measuring that because we only know what we have on our register.
Okay.
So it'd be good to explore that a little bit more with you.
Yeah, so we might be able to help with that, because we're going to launch our accreditation process probably in October, and then you'll know by what level a practice manager is at within that accreditation process, how much experience, what leadership skills they've got, and all those kind of things. So that might be something we can work on together and share that methodology with you. And
yeah, absolutely. And the more can be shared, Kay, at practice level, the more we understand around that leadership.
Fabulous, thank you. So you're linking in with us as the IGPM, and we'll have open and honest conversations both ways. We'll get the regional reps involved with the regional inspectors. And it sounds like it feels to me like a much more positive way forward for practice managers. So thank you for being open with us about those communications and that way of working forward. Now, I can see that our chat has gone a bit bonkers, and I can't see the questions or the comments in there, but I am guessing that Robin or Nicola or Joe have got a handle on some of those themes. Are there some themes within that?
There are. So so there is a question around how do we know if we're being closely monitored, Vicky?
So if you haven't got the statement or the banding, you will be within the group of practices where an inspector will be monitoring you closer. Now, it doesn't mean that we're concerned about risks. I think there's a difference. It just means that there is something within our system that indicates that the inspector needs to have a conversation with you at some point. So I don't want people to be alarmed by it. I think some of this is about inspectors working through. This is quite new for us. So inspectors will be working through some of this. So please don't be concerned about it. The inspector will contact you if they need anything.
And it probably is just a in a lot of cases probably is just that conversation, that assurance from the practice manager or the registered manager.
Yeah,
I can
sorry,
see
Kay, sorry, that just leads on, sorry, to say, how do we know who our CQC inspector is? So Kay kind of covered that by saying reach out to your regional rep, but if there is also some more clear guidance about who their rep is.
Yeah, so what I'll do, I'll pull some comms together just with, because actually we've got an inquiries system. So if you want to speak to your inspector, there is an email address that you can use that then gets, and the inquiry then goes to the lead inspector. We try not to give out sort of, you know, hundreds of inspectors' names with different practices. But if you actually want to speak to your inspector, you can use the inquiries email address and the message will go through to your inspector.
And we're doing that mapping exercise, so you can just go to your regional rep, your IGPM regional rep, if you're a member, and they will either get the CQC regional or inspector to get in touch with you, or pass on your details if that's appropriate. And you know, in some cases it might be a question that we can easily answer for you as regional reps. So there are some questions coming up on the screen as well. Joe and Robin and Nick, I'll come back to you if there are any more in the chat. If a practice asks for support, will this trigger an inspection?
No, absolutely not. Absolutely not. Yeah, no, I'll just say absolutely not, rather than sort of expand. But
yeah, fine. Will CQC take into account the pandemic, blah blah blah, blah patient data they collate in regard to surveys, complaints, etc.? That's a nod from Vicky by the looks of it.
Yeah. This is the importance of the assurance from the practice. So an individual complaint wouldn't necessarily trigger an inspection, but I would expect an inspector to reach out to the practice and ask the practice for assurance around how they're managing. Sometimes practices don't know, you know, one size doesn't fit all, but absolutely we're taking into account the pressures.
Thank you. I'm normally really good at keeping to time, and it's just after 1, but the numbers aren't going down in the participants list, so I'm going to keep going, but I completely understand if people have to leave, and we'll make sure we're recording the session. So next question, if you're only monitoring risk, what about surgeries who think they may need upgrading to outstanding?
Okay, so it's an important point. For us at the moment, it is not a priority for sort of, say, on the safety side of things. It's a really tricky one. And as a regulator, we've got a role around improvement. But sort of going back to the previous question, it's a really tricky one as to do we actually stand up inspection activity for those practices that want to demonstrate improvement from good to outstanding. We're having ongoing conversations about it. We are going to be doing a process of quality assurance for practices rated good and outstanding in order to understand how many of those that were previously rated good and outstanding are still good and outstanding. We're going to be doing that this year, and we're going to be doing it through some remote activity, not inspection activity.
Okay, and will you let us know what that remote activity is so that we know?
I can tell you now, Kay.
Okay.
It'll be 239 practices this year that are currently rated good and outstanding, and it will involve the clinical searches plus a conversation with the practice.
So the clinical searches happen with consent. You said you have to ask us to do that clinical search, so we'll know.
This won't happen. This remote activity will not happen without engagement with the practice.
Okay.
Practices will know about it.
Okay.
Yeah.
Great. Okay. Gosh, more questions coming in. How do we find out our local inspector is? We've covered that. How will CQC adapt their approach for staff who work in a number of practices, i.e. PCN employed?
Yeah. So really, really important. The ARS scheme, it's a whole another conversation that I'm happy to have with you, but I can't cover it in 1 minute, let alone cover it in 5 minutes, 1 minute. would welcome the conversation. Really important for us. One for you to remember is that we regulate practices, we don't regulate PCNs. So anyone working within the practice, regardless of where they are employed or what their contractual arrangements are, if they're working in your practice, delivering regulated activities in your practice, the practice are responsible in regulatory terms. So things like if you've got somebody working in a practice on the R scheme through the PCN, make sure that you've got the assurance that they've been properly recruited, properly, and are being properly supported, supervised, etc. Happy to have another conversation, but remember it's the practice's responsibility regardless where the person is employed.
Okay. Right. And I think this is our final one. Do you have a rough idea what inspections will be like from April 2022? And I think we can answer that and say, not yet, but you'll come back and talk to us in the new year.
Definitely will come back. We won't be shifting back to fully comprehensive inspections on the frequencies that we were before. Our future model is going to be based on the journey that we've taken so far. So really moving into the monitor intelligence, understand as much as we can without actually stepping over the threshold. So we won't be sort of going back. We'll be going forward and building on the work that we've done so far.
Great. So team, anything else before I move on in the chat? Anything else that we need to just quickly cover?
Just to follow up from the PCN question, Vicky, we've been asked if a staff member is taken on under a service contract and the clause says that the governance has been done, does the practice still need to be able to provide evidence of that to the inspector?
What is helpful is if you've got the written, you don't need the evidence of the actual detail, but sometimes and I'm sorry that it's escaping me, the sort of contractual arrangement. So if you've got a written agreement with the PCN, you don't need to actually provide. For example, we won't want to see references. We just want to see the fact that people have been recruited safely, and you've got it in writing.
Cool. And then lastly, just another question. If practices forming a PCN carry out extended access for a number of practices, has the PCN got to have its own registration, or is the service run under the individual practice registration?
Gosh, that's
complicated. So we've got, there's some guidance on that. I think that might be less about the PCN and more about, because this was an issue before PCNs.
And there is organizational working, isn't it?
Yeah, and there is some guidance on that, and it's about who's kind of the lead responsible practice that may take on the responsibility for the whole lot. There's a number of different models, the different ways you can do it, but there is some guidance.
Okay,
would you be able to? Yeah, would you be able to just send us that guidance, Vicky, and we'll send it out to our members?
Yeah.
Brilliant, thank you. I am going to stop us now because it's 1:10 and I know you'll all be have your next meeting or your next event, or someone, if it's anything like my office, putting their face against the window in the door wanting a piece of you. So just a reminder of what's happening next for us. So big session next week. I will be amazed if I can keep it to half an hour. PCSE, lots to talk about with PCSE. And then we've got Krishna coming. That's a little bit later. That's in September. And then Nikki's going to come to us during, I think she said, October. So lots of events planned moving forward. But I just want to say a really big thank you to Vicky for today, because I think this has been so helpful. The unscripted sort of version of CQC is, I know it's scary, Vicky, but it's been really, really good for us to hear from you and to take some of that fear away, I think, of the inspector, and understand that it's a much more collaborative approach with that background, that actually we need to make sure that our patients are safe, and that's what we all want, and that they're all getting that good care. So thank you from all of us. Nicola, do you want to just finish off the session and remind people how they can help us?
Sure, happy to. So don't forget, we think we represent really good value for 50 quid a year. So if you haven't already joined, please do. We are working our butts off, but we're working free of charge. But we do need to pay somebody in the background to do all of this admin for us. So we're using that money towards our next campaign as well, which is around signposting and educating patients, which is really important. Don't forget, anything that you see on social media, please retweet it, include as many people as possible. Speak to your LMC if you haven't already done so. Some LMCs are doing bulk purchasing of memberships, which is great because that gets a lot of you on board really quickly. Let us know what your ideas are. We've come up with a few ourselves, but we're really, really open to your thoughts. If you can think of ways that we can make money, you know, any ideas for campaigns. Make sure your GPs are on board as well. It sounds really daft, but there are some doctors out there who haven't heard about us, so get them on board. Colleagues and your deputies, it's really, really important that we future-proof primary care. So we need your assistants to be members as well. We need to support them to be able to take over what is an incredibly difficult job. Don't forget your logo footer. When you're a membership, you get the nice little badge at the bottom of your email to promote us. Just email any one of us. Our emails are out there. You can go to the IGPM website, you know, talk to us. We're here if you need us. You've got your regional reps, and do make sure you look after yourselves. Take a break. Hopefully everybody's had a chance to have a sandwich and a coffee while they've been on the webinar. And we are here. We're not going anywhere, guys. We're here for the foreseeable. So, you know, get on board. Pay, give us your money. This is my Bob Geldof moment, as everybody says. Give us your goddamn money, we need it. And yeah, we're going to go on to bigger and better things.
Fabulous. Thank you, Nicola. So a reminder, we are practice managers working as practice managers, and we'll continue to do so. We're not for profit. And you will always be the most important part of what we do, and we'll be able to continue and bring people like Vicki to talk to you directly as the IGPM. So thank you all for coming. Special thanks to Vicki, and we'll look forward to seeing you all next week. Take care of yourselves.
Thanks.
Bye.
Thanks. Bye-bye.
I think recording can stop now.